All right. Good afternoon, everybody. Thank you for joining us. This is Marcella McGuire from CSH. We are here for today's HRSA-sponsored webinar, Strategies Addressing the Opioid Crisis for Health Centers. We can go back to the previous slide. We want to give folks a little bit of guidance on WebEx. That's great. We'll be starting our session shortly. If you have a question, if you want something our panelists or us to address, please click and give us a message in the chat box. Having audio trouble, most times people can come in and go, close the WebEx window and relaunch it. That's great. And then please be aware that for everyone who signed up for the webinar today, that will receive an email shortly that will have the webinar that we'll send out as a link. You'll get the webinar as well as all of the reading materials. All right, so thank you everybody for joining us. Next slide. As we said, today's topic is addressing the opioid crisis, effective strategies for health center. We want to wish everybody a happy Valentine's Day, and thank you for spending a little bit of that time with us today. Next slide, please. First, I want to introduce everybody to CSH. We are a HRSA National Cooperative Agreement technical assistance provider, and we've been doing work for the past 25 years to advance housing solutions that improve the lives of vulnerable people, maximize public and private resources, as well as build strong, healthy communities. We're a national nonprofit, 25 offices in 13 states, and we're really happy to be here today and share some really important information with you. Next slide, please. I want to introduce our panelists. As I said, my name is Marcella McGuire. I'm with CSH and based out of Philadelphia. In addition, we have Brett Poe. Brett's a research associate with the National Healthcare for the Homeless Council, and he's going to be giving us a national perspective, some really important information in regard to the epidemic. And then we're going to be talking to two providers today who are really on the front lines of these challenges. Brian Colangelo is the Director of Behavioral Health Services for Project Hope in Camden, New Jersey, and Vicki Serrano, who's with Mental Health and Addiction Therapist with Family Health Centers in Louisville, Kentucky. So thank you all for joining us today. And next slide, I believe, good. Today's agenda, you'll hear a couple of pieces. Brett will give us a national perspective, as I said. You'll hear specifically from the communities. We'll have a facilitated discussion of really important questions that we think communities are grappling with, that we think health centers are trying to find the places where they can really contribute to solutions in regard to this crisis. And then we'll have an open Q&A. We are on from 2 o'clock now Eastern Time until 3:15. So we look forward to this conversation. We'll start with the national perspective from Brett. Brett, please take it away.
Great. Thank you, Marcella. So I am Brett Poe, and as she said, I'm a research associate here with the Council on the research team. And if you're not familiar with the Council, we have a national cooperative agreement with HRSA to provide training and TA to HCH health centers and lookalike health centers. And so from that perspective, again, as Marcella said, she wanted us to provide sort of a national framework here for this presentation. And because of the increasing need to address the opioid epidemic, last summer the Council released a fact sheet to kind of address some of these topics. So Rebecca, if you want to go ahead and go to the next slide. So just some general national information here. At the time that we released that fact sheet, the Center for Disease Control and Prevention reported that there were 142 Americans die from opioid overdose every day. And since 2000, deaths due to drug overdose in general have been steadily increasing. Specifically, opioid overdose in 2016 was 5 times higher than it had been in 1999. And we can go to the next slide to see how that kind of looks. And again, this map here is from the Center for Disease Control and Prevention. And since 2000, deaths due to drug overdose in general have been steadily increasing. The heat map indicates deaths from drug overdose have increased in nearly every county across the United States, largely due to the explosion in prescription painkiller and heroin addiction. And just to kind of look into this map, what you're seeing here is the spread of increased overdose deaths in general, so not specific to opioid here on this map. And you can see that spread by the increased area of the dark red cells, and those represent the highest amount of deaths per 100,000. And this is going back from 2003 to 2014. And we can go to the next slide. And so also according to the CDC, of a little bit more than 47,000 deaths that are caused by drug overdose in 2014, nearly 29,000 or 61% involved opioids. And that's the highest number of deaths ever reported since the measure had been recorded. And then also want to draw your attention to the sharp uptick between 2013 and 2014. And that shows that death by opioid overdose increased there by 14%. And compared to 2013, that represented a 6.5% increase relative to total deaths by drug overdose. National death rates by opioid type is what you're kind of seeing there in the bottom portion of that graph. From 2013 to 2014 also increased specifically by 9% in prescription opioid or pain reliever, 26% for heroin, and 80% for synthetic opioids. And those include fentanyl and opioids other than methadone. And just the general trend line there is indicating that from 2000 to 2015. And again, this graph comes from the CDC. So looking at where addiction intersects with homelessness, we know that housing is a major social determinant of health, and that lack of housing has been shown to negatively impact physical and behavioral health among individuals experiencing homelessness. And addiction can cause and prolong homelessness, and the experience of homelessness complicates the ability to engage in treatment. And we can go to the next slide here. So some comorbidity factors to consider here. We know that individuals who are homeless rarely have substance use disorders alone, and we know that there's comorbidities in play there, particularly with regard to mental illness. And in a national sample, 75% of patients experiencing homelessness with a past year substance use disorder also had a comorbid non-substance-related mental illness. And also, in addition to substance use disorders and serious mental illnesses, many people experiencing homelessness have acute and chronic physical health problems and histories of trauma. And so, again, I just want to draw attention to a policy brief that our policy team put out last year, or possibly the year before the fact sheet came out, that really just draws attention to the fact that these factors combined really translate into persons experiencing homelessness having much higher rates of substance abuse disorders, poorer health, and just a greater risk of mortality in general. And then there was also a study in Boston that both the fact sheet and the policy brief reference of individuals living on the street and in shelters that reported 1/4 to 1/3 having alcohol use problems and around half having used or abused illegal drugs. The Boston study also supported that opioid overdose is one of the major causes of death among people experiencing homelessness, and individuals experiencing homelessness in that study were 9 times more likely to die from an overdose than those who were stably housed. And then again, compared to the 61% of overall overdose that we saw was opioid-related on a national level, among those experiencing homelessness, that's 81% of overdose deaths were caused by opioids. And that is 13% of that 81% is from heroin. And we can go to the next slide from here. So just to kind of draw along that correlation with the comorbidities again, this graph shows some trend data. This data comes from the Uniform Data System Report, and this is submitted to HRSA annually by all of the HRSA-funded health programs. These numbers on this graph specifically represent those that are reported by HCH, or Healthcare for the Homeless, specific programs, and these numbers on the left indicate patients with these particular diagnoses. And so what we're really trying to point out here is that we see that the increased trends the same across substance abuse, which is the middle blue line, as well with the mental health diagnoses, and the highest among those diagnoses being depression, which is the top blue line. And then so also in 2016, the Council facilitated a provider-engaged discussion during one of our fall regional trainings to address the opioid crisis. It was something that the providers that we serve and provide TA technical assistance to told us that they wanted us to address more specifically. So we had participants answer questions on the greatest challenges that they see for their patients in reaching recovery, and we discussed best practices and programs that they use to connect patients with care. So this chart is a summary of those common barriers, successes, and resources that were identified by those participating healthcare providers. And just to draw some attention to some of these here, the greatest challenges around substance abuse, some that I noted that shared some significant themes were the complexities that relate to dual diagnoses, patients' readiness to adapt to a new lifestyle, not everybody being interested in faith-based programs, and then sort of on the flip side of then how they were addressing those challenges through medication-assisted treatment, updating resources, harm reduction, and solution focus. All of those things sort of center around the idea of program flexibility versus rigidity, which seems to be, the rigidity seems to be more of a theme in those challenges that we saw there. So moving forward, we'll dive into some of those a little further. You can go to the next slide. So some of those systemic barriers that were highlighted by those providers were that policy changes or rigidity of programs sometimes mean that patients are recommended or might be referred to programs that they end up being ineligible for. Or if not that problem, then potentially a lack of available resources within a program. So once a patient has met all the requirements or they are eligible, they may find out that the space in the programs may not be there. And all of those things together can lead to a loss of hope in their recovery or a general distrust in the system, is what we were hearing from these providers. Also, lack of enabling services can include lack of transportation services, lack of flexibility around work schedules or childcare, the associated costs of treatment or copays or premiums, as well as loss of coverage can all present challenges, and reduced access or provision of doctor-supervised prescriptions. You know, and a lot of this may be coming from a response or standards that are reactions to the epidemic, but by reducing the dispensing of pills to treat chronic pain, this may then in turn increase self-medication or the use of street drugs or heroin for some of the individuals who are homeless who now can't get it through a more regulated or supervised method. So go to the next slide here. We did get some promising practices from our providers, and they let us know that they do have some ways that they deal with most of these barriers. And they mostly include, again, making resources available to patients seeking recovery, maintaining access to resources, and approaching recovery with what's best and realistic for the patient. And again, that focus on more solution-oriented, flexible, and less rigid. So they said that it's important that there's a shift from program-first to person-first ideology, such that it's not whether the individual meets requirements, but more rather when the individual is ready, when they make the decision or self-initiate to enter into a program, that program then is going to be readily accessible without any inhibitors. Also emphasizing that housing-first approach can establish stability, and that's known to greatly affect the health and the success of recovery. Some recovery housing works with patients, driving the decision-making process or living among their peers to establish a support system, or utilizing housing case managers or continuums of care programs, and those can help identify those types of local resources. And also, it's important to provide choice on recovery paths, and that one-size-fits-all type of approach often introduces challenges, and again, that rigidity can lead to unsuccessful recoveries. And again, when housing is unstable and abstinence may be too drastic of a lifestyle change, harm reduction practices are an alternative option for success at recovery while living on the street. And again, we know that medication-assisted treatment or the use of medications in combination with counseling and behavioral therapies can provide treatment to persons experiencing homelessness that is patient-centered, integrated, and takes a more harm reduction approach. So some additional fact sheets and resources that we can draw your attention to, again, addressing the opioid epidemic is the fact sheet that we put out last summer. Towards the end of that fact sheet, we have an array of resources that you can utilize that include tools and strategies to address the epidemic in the healthcare setting, and also just to gain a better understanding of how this epidemic affects people without homes. The policy brief that I mentioned, it is called Medication-Assisted Treatment, buprenorphine in the HCH community, and that was developed by our policy staff. And that is also linked here as well. And I believe that these slides will be made available to everybody here that's on the call. And I also wanted to draw attention to an upcoming fact sheet that is currently being reviewed by HRSA on suicide and homelessness. And one of the things that I thought might be interesting there is just some additional data that shows the role of death by substance use as it relates to suicide. And that was just sourced by some different data collection tools than what we typically use. So we do have some things there from the uniform data system, but also from the CDC system called the National Violent Death Reporting System, and it can break some of that down in a little bit more of a detailed fashion, and hopefully that will be available within the next month or so. And then also, I didn't put this here on the slide, but also wanted to make ourselves available at the council as a resource for TA if it's something you want to look more into. Over the last year, we've received about 7 or so specifically related to the opioid epidemic. And primarily, we're receiving those from other sites that are requesting linkages to specialists to train their own personnel, or if they're looking to hire specialists for treating opioid use disorder to work with their patient base, or also linking up with other HCH sites to find out what types of models of treatment the other sites are using, or to identify best practices and develop policy in that way. So those are some of the ways that we can provide training or technical assistance for you or make those connections for you if that's something that you're looking for. So hopefully I didn't take up too much of my time, and from here I'm going to go ahead and pass this over to Brian.
Great, thanks so much, Brett. That was fantastic information. So my name is Brian Colangelo. I'm the Director of Behavioral Health at Project Hope here in Camden, New Jersey. We're a relatively small QHC, the Healthcare for the Homeless. So I'm going to talk to you and tell you a little bit about who we are, and then I'm going to go into our buprenorphine treatment for opioid dependence and talk about our medication-assisted treatment and what we've done and what our successes and challenges have been. So looking at the next slide. So we are pretty well integrated FQHC. We're located in Camden, New Jersey. It's a urban area, almost 80,000 residents. We're ranked as one of the most economically depressed cities in New Jersey. Unfortunately, often make the list of poorest and most dangerous cities in the country. So we have a number of challenges that we face here in Camden. One of only 3 FQHCs in the area. Next slide. So we're a standalone FQHC, 330. It's actually 330H. We started about 15 years ago, simply as an outreach street medicine team. Right now, we're seeing about 4,000 patients a year for about 18,000 visits. Staff of about 40 people. We have a 340B formulary. Next slide. We offer primary medical care services, laboratory services. Again, we have a pretty robust behavioral health department. We have a mobile health van that we do outreach and some street medicine services with. We see insured as well as uninsured, no residency requirements for treatment. Next slide. So this is just to give you kind of a sense of our staffing breakdown, where we've got 4 prescribers, 2 doctors and 2 APNs. All 4 are waivered to prescribe Suboxone. I'm a full-time psychiatric nurse practitioner, part-time psychiatrists. We're fortunate to have 4 LCSWs and 2 drug and alcohol counselors, 3 RNs, 4 MAs, peer advocate, case management, and then support staff. Next slide. So I think what was unique about us jumping into the pool of doing Suboxone treatment was recognizing that these are our patients. The one slide that Brett had up there in terms of the comorbidities, I think really speaks to the fact that most of our folks don't come in just to get their diabetes treated. Folks come in and they're looking for help with their diabetes, and their biggest complicating factor is some sort of behavioral health issue, and in a lot of cases, an opioid dependence. To see over the years the resistance of some agencies, some individuals, and people who I think have that fear, that concern, that lack of understanding about what that is, I think we were fortunate in that we recognized early on if we wanted to adequately treat someone's diabetes, we needed to address what those comorbid issues were. So we were never going to be able to bring someone's blood pressure down when they were actively using heroin, because their priority was not taking their blood pressure medication. Their priority was how do they keep themselves from going into opioid withdrawal. Essentially, how do they stop from being dope sick and being so significantly, hurting so significantly much. So we realized that for all of our care, we needed to have a much more holistic approach. In the community, I think is the case with a lot of other places, the access to treatment was, your choices were methadone or private Suboxone prescribers in the suburbs. So there were a number of good prescribers in the suburbs who would prescribe Suboxone, but they were private, cash-only businesses. So you generally would need to shell out a minimum of about $300 for a first visit, and then it was anywhere from $100, $150 for each monthly visit. So not only was that a significant barrier for most of our patients, even just getting out there was a challenge. They generally didn't accept insurance, and that just wasn't a service that our patients had the ability to connect with. So that was the main reason that we really started doing this. Is our patients were coming in, they were asking for, hey, do you prescribe Suboxone? What is it? What would it look like? How would it help us? I think at the time, and it's been about 5 years now. It's been 5 years now since we started doing it. There was a little bit less knowledge at the time, but people were starting to become more aware. People were starting to become better educated. People were starting to specifically look for that type of treatment. So one of the things that was fortunate for us is that we had a physician on staff at the time who had some experience prescribing, and he was instrumental with being able to help train and get everyone on board. I think one of the challenges is just even starting it. So, a few things that I would suggest as far as the hows and the whys are being able to access adequate training. I think treating addiction is a scary process for a lot of folks, whether you're a primary care provider, doctor, or even if you're a behavioral health staff member. There's still a fear, there's still an uncertainty, there's still something that makes people a little bit hesitant to want to get into it. So having the experience of having someone who could kind of hold our hand through some of that made a big difference. A lot of it isn't stuff that you can always learn from going to the conference or going to the workshop. While they serve a great opportunity for knowledge, I think a lot of people's fear and uncertainty comes from not being able to ask questions in the moment, not knowing what to do. And I think those are things that we still struggle with, and we still, as we talk to and communicate with other providers, try to figure out, hey, what is it that you're doing and how are you doing it? I think, again, the idea of trying to reduce the program rigidity and improve more of a patient-centered approach means that with each new challenge, we have to figure it out in the moment. So how do we figure out what that problem is and then identify a solution for that patient rather than creating an across-the-board rule that's going to exclude people from treatment. So next slide. So again, we started this in 2013. I think with the numbers there, we've probably seen about 800 people that we've prescribed buprenorphine Right now we carry a panel of about 200 people. Our providers are at the max for their waivers, which we honestly internally we wouldn't have the ability to do. So each of the physicians is waivered at 275. Each of the NPs are waivered at 100. Internally, we wouldn't have the ability to see that many and prescribe to that many people just because of the commitment that's required for urine drug screen testing, for counseling, for management of those panels. So we've kind of found a nice balance that we're able to handle ourselves at somewhere around 200 people. And again, that's one of those things that we talk to other folks who are interested in getting into this type of work. You can start with one person. You can carry a caseload or a patient panel of 5 people if that's comfortable for your practice. So if you're a small practice in a small area and you don't have a huge staff, or if you don't have an agency that's really willing to get in and take this all on full force, you can do this with 5 or 10 patients. You can maintain and manage a small panel in an effort to just start doing it, see how comfortable you are with it, devise some of those work plans and those workflows that will constantly need to be adjusted based on so many different things, based on the type of staffing that you have, based on the types of personalities, based on your physical layout. I mean, you know, we moved into a new building about 3 years ago and realized that just even the new layout of the health center required us to make changes to our workflow in terms of how we see patients, how we process urine drug screens, how we triage folks, how we move them from staff member to staff member. Generally, we again, as having a robust behavioral health department, we're able to provide both individual and group counseling through our LCSWs as well as our alcohol and drug counselors. Patients are seen anywhere from weekly to monthly. We don't really have the ability to see folks on a daily basis. If people get to that point where they need that type of level of care, we'll refer them for a higher level of care, like to somewhere like the methadone center, if they need a daily dosing of that ability. We do work as hard as we can on reducing diversion. The numbers I've seen are that somewhere close to over 80% of patients at some point divert some of their medication. It's a reality of the population, of the world. We do our best to reduce as much, especially overt diversion, as we possibly can. But we also recognize that our primary goal is that of treatment providers, not of, we're not the police, we're not the legal system. So trying to make sure that patients are taking their own medication as best they can and not selling it, giving it out to other people. We use urine drug screens. We do pill counts. We also do oral swabs. We do a lot of education with both patients and staff to try to help them identify and recognize what the issues are. We run the prescriber reports for all of our patients through the New Jersey prescriber system. So again, we do as best we can. We don't spend all of our time in an effort of trying to catch people. With the idea being that our focus is on providing treatment. Next slide. We also, just to touch on, talking about medication-assisted treatment, it's not just Suboxone. So we do a bit of the naltrexone injections, Vivitrol. Been doing that for about the past 4 years. We've seen over 200 patients that we've done injections for. We probably do about 15 injections a month. For the most part, most of those folks often come from the Department of Corrections, so they're referrals from people getting out of prison or jail, parole or probation, loves Vivitrol. To them, they kind of see it as a cure-all or a fix. So we do a lot of education, both with the patients and with the parole officers, probation officers, just so that they understand what it is, how it works. But it is very effective for a lot of folks. One of the biggest challenges we have are our insurance prior authorizations. So for the Vivitrol, it's 24 to 72 hours is probably generous. In some cases, it's longer than that. In New Jersey, the New Jersey Medicaid Managed Care Organizations, we have 4 of them. They vary, but none of them are particularly great. So they vary in terms of how quickly they'll get the prior authorizations done. Vivitrol averages, I want to say, about $1,200 an injection. So sometimes they can be a little bit tight with that. Issues with our internal protocols, again, so I kind of talked about urine drug screen testing, how we do that, how we utilize oral swabs if we need confirmatory tests of the urine drug screens. Issues that we run into, we do a lot of Narcan training with our patients. We prescribe Narcan to every patient who gets a prescription for a medication-assisted treatment, whether it's Suboxone, whether it's Vivitrol, anyone with an opioid dependency diagnosis, anyone that's on a chronic pain medication, anyone who might possibly come into contact. We also do education. We were also fortunate to be able to get some Narcan kits that we were able to give out, so we're able to give those out to people who aren't our patients as well, so family members and friends of someone who's the patient. So we can't necessarily write them a prescription if they're not a patient, but we do have the ability to provide the Narcan to them. Next slide. So one of the things that we've worked on, one of our more recent projects that we've been excited about is trying to get more of this treatment and this method available and out in the community. So we really were the first in Camden to start doing this work, and it's been great to see it grow. There are now a couple other providers who are doing similar work, and it's exciting to see their treatment programs kind of modeled around how we've done this. So one of the things we've started doing is we do a monthly Suboxone breakfast, and what we're trying to do is recruit some of the other providers and prescribers in the area to be able to provide them with the education, the comfortability, the understanding, the knowledge around, hey, this is what we're doing, and this is how we're doing it. And those questions and those fears you have about what happens when the patient does this, what do I do? There's a group, there's a community that's available there to answer. And so, so it's been neat being able to bring everyone together. We meet once a month on a Friday morning. We host it here at our health center. And again, kind of give some of the other prescribers and some of the other agencies in the city an opportunity to ask questions, talk about things, share resources, or even just vent about, what some of the challenges are. And then the last thing I'll touch on is one of the other big resources for us were the Project Echoes. We participated for a year with one of the Project Echo, the buprenorphine Project Echo, which was done through the Weitzman Institute in Connecticut. And it was a once-a-month webinar, teleconference call with real-life case presentations. So you'd present a case, there'd be an expert board of people that would give feedback and kind of advice on what to do, where to go, and how to work with those patients. And so that was an excellent resource for us for being able to do this work. But so I think with all of that, I think the biggest thing I want to say, in the short period of time we have, but just I think to continue to emphasize, A, the need for the work, the lack of availability of this type of treatment that's out there for our patients. And again, just recognizing that these are already our patients. These are the folks that we're seeing. And again, for us to be able to best treat them, we need to recognize that doing as much of this stuff as we can in one setting under one roof is, the evidence has showed that that's the most effective method for them to be able to get the best results. So thank you. I appreciate your time. I appreciate everyone who's called in and participating in the call. And next, I'm going to turn things over to Vicki and hear what she has to say. So thank you.
Thanks, Brian. Can everybody hear me okay?
Sounds good.
Yep, we can.
Okay. I'm Vicki Serrano. I'm a licensed professional counselor and licensed clinical alcohol and drug counselor in Louisville, Kentucky. The last 5.5 or so years, I've been working with the homeless population out of the family health centers. Family health centers, just a little bit of history for the organization, opened in 1976. The Family Health Center, or the FHC, is a 501c3 nonprofit corporation that was established by the local Board of Health, and it's one of Kentucky's largest federally qualified health centers. We are a member of the National Association of Community Health Centers, a founding member of the Kentucky Primary Care Association, and the Louisville Primary Care Association. And the FHC is the second longest Joint Commission accredited community health center in the United States. Family Health Centers serves an almost 400 square mile area of Jefferson County in Louisville, Kentucky, with the entire metro region having a population of approximately 1.2 million. The communities that Family Health Center serves range from medically underserved inner city neighborhoods to semi-rural residential communities, all sharing the common characteristics of being predominantly low income, lacking access to basic health services, and experiencing a poorer health status than residents living in other area communities. The Family Health Center has 8 freestanding sites located throughout Louisville Metro. The site I work at is the Phoenix Health Center. Phoenix named after its neighborhood, Phoenix Hills. Our center is a designated healthcare for the homeless site. We only serve those who are homeless or who have been homeless and are now residing in supportive housing. So just a little bit of some stats for our local area. In 2014, there was approximately 11% of Family Health Center patients were considered homeless. The Centers for Disease Control and Prevention ranked Kentucky 4th in the country for narcotic prescriptions, with our neighboring states ranking 1st through 3rd. Kentucky overdose fatalities in 2014 numbered over 1,000, with Louisville having the highest number at 204, and nearly 50% of these deaths were heroin-related. The number of people booked on heroin-related charges in Louisville was 100 in 2014, and that was up from 1 in 2011. The Medication-Assisted Treatment Program here at the Phoenix Health Center, or the MAT, the M-A-T, it began in 2016, supported by a HRSA grant. We prescribe Vivitrol. We utilize urine drug screens. We offer individual and group therapy. And all the staff at our particular center is trained to use Narcan. Our referrals to the substance abuse program here come from the Department of Corrections, come from treatment providers, come from shelters. And the substance abuse program here is connected to area inpatient and residential treatment providers. One of the big things I think we're proud of here at this site is we have a really good interdisciplinary team, and we're all housed under one roof. So what I'm going to do now is just kind of go over a few of our bragging points and then some of the challenges that we are facing here in our center. Approximately over about 60% of our patients here at the Phoenix Health Center struggle with a substance addiction, and we do have the resources now to serve them. We have licensed counselors with experience. We have the Vivitrol. We have medical, educational, and social services case management services all under one roof. Folks in the substance abuse program at this time can be treated by a therapist several times a week if necessary. We have some educational support groups also that they can be involved in. As I'm sure many of you know, the homeless tend to be a rather transient population and without transportation. Our center is very conveniently located within walking distance of a lot of places downtown. It's close to several shelters, close to the hospitals, and it's on several city bus lines. And again, having all disciplines under one roof really improves the likelihood of our patients receiving more than just one service. So, you know, you'll often have a situation where somebody will show up for one appointment. You know, I'm here to see the doctor today. Well, I might as well talk to the therapist or something like that. So we can kind of keep them in here and reach them on different levels. We also, as we have a medical department, we do our own lab work in-house. That comes in pretty handy when you're talking with starting someone on Vivitrol. We can do the lab work to see, you know, if they're going to meet criteria for that in-house. Another big positive here is that we have a really good housing case management team that work out of, I think, some SAMHSA grants. So we have a team of housing case managers that do outreach and wraparound services to the homeless population. They assist them with gaining supportive housing, help them fill out applications, leases, help them to get to and from appointments, help them with picking up their meds, help teach them various life skills, etc. This program is a Housing First program. Some of the challenges here, I think locally, again, the transient nature of the homeless and, as it was addressed earlier, and the often co-occurring disorder nature of the homeless results in a lot of missed appointments, non-compliance with meds, struggles to maintain sobriety, and chronic medical issues. Some of our addicted patients who come for Vivitrol are still using or are in active withdrawals, so we have to wait before we can start them on Vivitrol, and when that's the case, some of them don't come back. Many of our patients don't have a telephone or a consistent place to stay, and that can make it challenging for us to reach one another for information or appointments. And probably like most places, there's just not enough supportive housing opportunities locally. A really common theme that as a therapist I see with a lot of my patients who have been homeless for a while and then they are housed is, they kind of experience this newfound independence, and that can be a wonderful thing, but it also results in typically increased isolation and a decreased feeling of accountability to stay sober, whereas if they're staying in a shelter or some sort of halfway house or program, they may get kicked out if they, test dirty or something, but in their own place, of course, there's no one watching out for them. Another sizable challenge here for us locally in Louisville is that one of our prominent shelters has a recovery-based program. However, they will not allow their participants to be on Vivitrol. That's, of course, a difference in, I guess, theory of recovery. But I've had a lot of patients from those recovery-based shelter programs come to me wanting to get on Vivitrol to help with the cravings, and then they find out they're not allowed to stay in that program if they take it. Another, I don't know if this is a challenge or not, but I have my thoughts on, possibly including Suboxone in with our medication-assisted treatment program here along with the Vivitrol. As I said earlier, a lot of patients will come to us who are in withdrawals or really cannot get to 7 days clean, which is a requirement before you start Vivitrol. And the Suboxone, I think, could really help a sizable amount of more people. Let's see. We work really closely with our housing case managers. We have monthly case review meetings with them. So we go over, a lot of different individual cases and see what needs are still not being addressed. We at Phoenix, I think, treat folks from a holistic perspective, meaning, that a person's psychological, social, and physical needs are very interconnected. And again, we're kind of a one-stop shop here, so they can get all those needs met here. And as this population, the homeless population, is typically defined by having a variety of struggles and issues, I think, having an interdisciplinary team in one place is critical. I think that covers what I had. So, Marcella, I'll send it back to you.
All right, that sounds great, Vicki. Thank you so much. Just a couple of questions I had after that conversation. Vicki, I'm going to start back with you. Are there any opportunities? I certainly heard what you said in regard to, some of medication-assisted treatment, and Brian, jump in here as well. What's the opportunity in order to educate people about what that means? The concern that people lose their housing when they're doing what's important for them in their recovery. How do we sort of engage people who, might not have the best understanding of medication-assisted treatment, how key it is to many, many people's recovery, certainly the research behind it. How do we do that engagement?
Well, in Louisville, I think there is opportunity for different community providers to collaborate in community and coalition meetings, newsletters. There also is, I think, some competition felt in our local area for Suboxone and Vivitrol, so I think that's a bit of a challenge here as well.
Competition because there's not enough capacity, like not enough prescribers. Is that what you mean when you say competition?
Well, what I mean is some of the other substance abuse treatment providers in the area who have inpatients and have detox services, one of them I think is starting to use Vivitrol. The other one I think has Suboxone and Vivitrol. So I think there's some competition of, who's going to get the patient maybe.
Okay. Yeah, sadly, I think there's more than enough to go around, just like those of us who are working in homelessness find that, right? There's more than enough,
right, exactly.
enough folks to go around. Yeah, Brian, have you seen something similar? What's some strategies you've come up with?
Yeah, I think you had asked about kind of the education part. I think it's really important as far as how do we bring people around to having a greater understanding, embracing medication-assisted treatment a little bit better from other programs, from housing programs, from more traditional substance abuse providers, to the legal system. I come at this from a perspective of, I'm a social worker, I'm a therapist. That's where my heart and soul is. That's what I believe in. But I'm also a firm advocate that medication works. It does exactly what it's supposed to do. And so I think I've gotten good at being able to have those conversations with folks to say, hey, this is what it does. And these are, I hear what your concerns, your fears may be, but this is kind of the realistic approach to why it's important for this patient to be taking this medication. And here are the potential outcomes for what's going to happen if they are or they aren't in your program, whether it's a housing program, an IOP program, and I would even expand that to family members and friends who say, why are you going to that place? Why are you taking the medication? You're staying addicted by using something else. And so I think that it comes from just a lot of gentle conversations in terms of being able to say, let me explain to you what we're doing. Let me explain to you what this looks like, what the medication does and doesn't do, and try to alleviate some of those fears. And so I think we've had a lot of those conversations over time with people, with housing programs, with case managers, with other counselors, with parole officers, with spouses. So, yeah.
No, that's really important. Thank you, and thank you for both of you for having those conversations and for supporting your staff as well. Brian, you talked about the connections to housing. Brett, you certainly highlighted how essential that is to someone's recovery. Can folks talk about sort of how you work with maybe the continuums of care or the coordinated entry systems in your communities? How do you stay connected to that sort of homeless network? And the health centers play a key role. Very few health centers play the only role in a community. So we'd love to hear about some of those partnerships and how you connect there.
Louisville has a coalition for the homeless, and we're directly involved with them, board representation, fundraisers. So we're constantly communicating back and forth with our local homeless coalition.
Yeah, similar thing here. You know, we're involved with our local company, the community of care, the local COC at the county level. We also are pretty active with the shelters in the area. I think they rely on us as much as we rely on them. You know, so being able to even provide physical services, screening services, basic health care for them. You know, probably the area that we have here in Camden, and I know it's different in other areas, is even the smallest distance apart creates a barrier for patients. You know, so we're not far from, you know, 3 of our local shelters, but it's still enough distance that you still lose a number of people going from one place to the other. You know, so I think the more of that you can have, the better. The more co-located services in terms of both the medical care and the housing. I think the evidence has shown that makes a difference as far as treatment. You know, so that the communities that have that ability, I know here in New Jersey, there's a model like that in Atlantic City where the health care for the homeless is located, one of their offices is located right in this shelter. You know, that helps reduce a significant amount of that barrier.
All right, thank you. Thank you both for that. A question came in, I think, Vicki, this is probably more for you, from Rona Alexander. They operate an FQHC in Western Kentucky. They want to initiate the Vivitrol program. They have 2 behavioral health employees that, like you, are licensed professional counselors. They want to do the counseling for the folks in the program. Our concern is that this is Ms. Alexander, have heard that they should not do the counseling portion without addiction medicine training. Is this true, and how can we help our behavioral health staff to train quickly in this area so we can get it off the ground both quickly and correctly? What would you say to that?
I guess my first question would be, you know, the behavioral health providers that you have, are they experienced with addictions? I mean, that's, of course, critical. As far as any sort of specific training for addiction medicine, of course, that's very helpful, but I don't see that as something that, you know, would be difficult to acquire. I mean, you could get that with some you know, trainings or workshops.
Okay, great. And that's thanks, Vicki. And if folks have other more specific questions and want to do follow-up, we're helpful to help try to facilitate and make sure folks can get connected to each other and, you know, just hear more details, particularly on that experience. Another question here, both of you mentioned opportunities for community partnerships. What specific instance do you think would be helpful to programs? How can business and legal communities best support the important work you all do?
I know in our area, you know, we've had an opportunity to work with the local police department, and they, for the most part, they've been pretty receptive. They, you know, we like a lot of other local police departments, have, you know, they carry Narcan. They've been very active with using it, you know, and that's been great. And we've, you know, they've invited us in, and we've had the opportunity to provide them with education about the treatments, what it does, why we're doing it, what to look out for. And they've been pretty engaged with that. I think they, you know, as stereotypically as much as they may come off with, you know, the kind of the traditional attitude of not caring, I think for the most part, most of them do care and are interested in engaging kind of in a more effective way, because they continue to see the same folks out on the street and, you know, would much rather not, and know that, you know, just continuously incarcerating them isn't going to work and it's not going to help. So I found that our local law enforcement has been pretty responsive, you know, during conversations and, again, with education.
In Louisville, I don't know that we have a very close collaboration with our local law enforcement. you know, of course, unless, of course, they're dealing with someone who is, you know, likely homeless. And, I mean, of course, the law enforcement is very aware of us and will give the person, you know, our name and number for a resource. You know, when folks are picked up here by the police, you know, they're typically going to go to either a psychiatric hospital or to our downtown trauma center emergency room. And again, as I alluded to earlier, I think here locally, I sense a certain competitiveness in the air around here, I think, for MAT programs. So I think there's some work that, you know, we will need to do, and everybody kind of getting on the same page, you know, especially since our center, of course, you know, we only deal with a very exclusive population. So I think some education with some of our community providers will go a long way.
All right, thank you, thank you. A couple more questions. Brian, you mentioned Project ECHO. Can you talk a little bit more about what that is, and if it's been helpful, also how people might get connected to it?
Sure. So Project ECHO was started by a doctor out in New Mexico years back. He was a gastroenterologist. He was the only one providing Hep C treatment in the entire state. So patients would have to go out, you know, travel hours in order to see him in order to get Hep C treatment. And so he came up with the idea of having the treatment done by the primary care providers in the patient's communities, and he would offer them training and support via kind of a webinar, a teleconference type of format. So he would meet once a month with anyone who was interested and do basically case presentations. You know, I've got this patient, this is the challenge, and then provide education, discussion, feedback. And so then that Project ECHO model kind of is spread throughout the country and with other issues as well. And so there's you know, there's any number of different Project ECHOs from you know, treating chronic pain to Hep C to all sorts of stuff. And again, there's an excellent one on buprenorphine done out of the Weitzman Institute up in Connecticut that meets once a month. And you know, so you dial in, you call in. It's a video conference. So you're looking at the panel of experts, and it's usually a holistic group that involves a primary care provider, a psychiatrist, addictions counselor, social worker, case manager, MA, and you know, they provide consultation on, you know, different cases. So people will call up with, hey, this is the challenge of the person that I've got going on right now. You know, what are your recommendations for what I can do? How should I approach this? How do I interpret these lab value results or these urine drug screening results that seem abnormal? What do I do with this person that's got all of these different you know, concurrent addiction issues? You know, what do I do with the person that's taking the benzodiazepines, smoking the marijuana? You know, what are more effective medications in certain situations? Well, how can I better dose this person on the buprenorphine? So all of that stuff, but kind of in a, you know, again, it's a live, real-time discussion and education about, you know, your current cases, rather than just you know, going to a conference and watching a workshop that doesn't necessarily give you direct feedback on what you're experiencing. So, yeah.
That's great. That's great. Rebecca, can you move to the next slide for me? A couple other questions we still have. You folks talked about how your agency started the MAT and the substance use disorder programs. I'd love to hear you talk about what was different about this program from your other services. Was there anything, you know, particular different that you had to do in order to really make this fit within your continuum of care or continuum of services?
In Louisville, as I said, we started in 2016. You know, we already had mental health and substance abuse therapy services But what was different is that I think, again, of course, adding the medication Vivitrol, but just, you know, having just having a substance abuse provider dedicated to the Phoenix Healthcare site, specifically for substance abuse addiction, and getting the buy-in, I think, from the whole corporation to support that.
Yeah. Yeah. Brian, for you?
You know, it's you know, we talk about that we do not have a Suboxone program. The reason being that we don't have a diabetes program. So someone comes in, they have a disease or diagnosis, and we don't look at that or stigmatize that any differently than we look at any other disease or diagnosis. So, you know, patients get scheduled the same. Patients kind of get processed the same way. You know, we try to avoid that. This is a separate program from the rest of the primary care work that we do. This is just part of their treatment. They come in, they get prescribed insulin for their diabetes. They get prescribed buprenorphine for their opioid use disorder. So we really try to push that. And at the same time, yes, are there some differences? There are. I mean, if we're, you know, to be completely honest, I mean, there are, you know, it does require a little bit more work than prescribing insulin. So, you know, kind of talking out of both sides of my mouth at the same time. So we, you know, but yes, so we do try to reduce the stigma. We do try to make it as much of the regular amount of care as we can. But we're also, you know, we're cognizant of we've got to do urine drug screens on these patients. We have to keep a kind of a very careful patient panel and listing of who they are when we're seeing them, copies of prescriptions. You know, just aware of if the DEA comes and does a site visit, so we have the appropriate documentation. So there is a little bit more work that's involved, to be honest. You know, but we've never found it to be overwhelming. Again, probably the biggest challenge and kind of resource challenge that we've had are prior authorizations. Again, and that's for both the buprenorphine and for the Vivitrol. Those are the biggest things that we've had the most difficulty with. We ultimately had to hire a part-time person just to communicate with the managed care health insurance companies in order to do those prior authorizations. And oftentimes there is a delay in treatment for the patients, meaning that we can prescribe them the medication, but a lot of times the pharmacy won't fill the medication for a day or two until the managed care company authorizes the medication. And that can be difficult. One of the things that we've been working on, United Health, which is one of our New Jersey managed care HMOs, has started with, just here in Camden with us and one of the other providers, what we're calling a gold card pilot project. And that is that because we're an FQHC, because we've demonstrated that we have, implemented these certain factors as far as our protocol and our process, that they've waived the prior authorization need for our patients. So we'd like to hopefully be able to take that, demonstrate that it's been effective, and start to get some of the other managed care companies to do the same. I know some states have had some success with some of their managed care companies already doing this. I know in New York, I want to say Aetna, maybe last year, did away with their prior authorization. So it's slowly changing. But again, I think that's probably one of our biggest challenges.
All right. Next slide, Rebecca. For both of you, talk about, are you involved in any local planning processes related to the opioid crisis? Is there any places where there's a lot of funding likely coming down in regard to this? How do you be sure and be a part of that process to be sure that it's evidence-based. We have another question from our chat, thank you, about, how do you on the one hand bring it up quickly to address the enormous needs you're seeing, and then of course the concerns about, being things done quickly often aren't the same quality. How do you be sure that there's, well, let's talk about local planning, and then we'll get into sort of bringing things up quickly to address needs. Talk about local planning if you can.
I'm certain that we are involved in local planning processes. However, I don't really have the knowledge of the details on that, so I'll defer to Brian.
Sure. So a couple of things. It's interesting to see, over the past couple of years, I think as the opioid epidemic has finally gotten more of the attention that it deserves, there's a lot more people getting involved. So, we see both some changes happening at both the city and the county level, and a number of different organizations starting to promote more awareness, do more education, do more advocacy work. So trying to be involved in as much of that as we can. And again, it's tough because any time we take out of the office means less time being able to see the patients. But trying to collaborate and trying to consult and help all of those partners and those resources, again, kind of better understand the process and what's needed. One of the things that we've been fortunate to be able to do is, talk to, the state here in New Jersey about needed changes. We've met with some of the state legislatures, the New Jersey Division of Licensing. Hopefully none of them are on the call, but they're always a pain in the neck. And they, there's these fine divisions between the Department of Health, the Department of Mental Health, the Department of Addiction Services, and it's slowly gotten better. They're slowly trying to bring them all together, but they still have their areas where it's just like, this is my territory and not yours. So trying to help them better understand, like, these are some of the barriers to treatment. Some of these licensing requirements that keep us from being able to do certain types of work, or keep certain agencies from being able to do certain types of work. How do we try to address them? How do we start to fix them? How do we, again, advocate at those levels to be able to say, the regulations need to be changed. So it's been interesting to kind of, and it doesn't happen quickly. It's to see that over time has been good, but it requires definitely a lot of patience.
Yeah, we appreciate the pull that health centers have pulled in so many different directions. And just a reminder, folks, I'm pulling questions from the chat box, so please feel free to, if you've got any questions, we've got a couple more minutes here and a couple more questions, but please put your questions in the chat box. Another one that came in from Rebecca Weir, you mentioned opportunities for community, oh no, that's the one we already did, excuse me. The second one we did from Carly Henderson. Do you have any concerns about the programs being implemented without adequate staff, provider training, and preparation? There's that really difficult line to walk between, on the one hand, it's a crisis and people are dying, every day, and it takes time to bring up a, positive quality program. Talk about how you, navigate that fence. Brian or Vicki?
Yeah. So, again, I think my first biggest recommendation, especially in regards to medication-assisted treatment, is, as I said before, starting small, starting slow, especially if an agency has limited staff or has limited support. If it's one patient, starting with that. Again, yes, there's, we definitely are in a crisis, and there's definitely a push, and everyone wants to kind of be able to do more because we're not doing enough. But you're right, we still need to be strategic. We still need to be thoughtful, mindful in how we implement and what we do. So it's not about just jumping in head first into the pool. It's about, right, how do we figure out how what we can do will fit. Again, one of the things that was unique about us as the the healthcare for the homeless as an FQHC was access. So, again, we recognize we have better access than a lot of the other more traditional agencies. So a lot of, we'd have patients come in and say, I can't get into treatment anywhere else. There's a 3-month wait. The community mental health agency has a 3-month wait before I can see the psychiatrist, before I can get in with a counselor. The rehabs are all booked up. So folks were coming to us because we have more immediate access. So kind of, all right, so we tried to look at, all right, what strengths do we have, what can we offer, and then also how do we fit in and partner with the other agencies as well. So again, recognizing that even, we do have limitations. So we do partner with the detoxes and the rehabs. We do partner with the IOP programs, the partial hospitalization programs, and those other community services that are necessary, but we can't necessarily provide. There's other levels of care, and so I think that's an important component of it too. Recognizing, we can't do it all, especially for our patients that come in and have a lot of comorbid, more technical issues. In the same way that someone comes in and says, I need help for my cancer, we don't say, great, we're going to roll up our sleeves and we're going to take care of all of it. No, we're also going to make sure we link you up with the appropriate oncologist, recognizing that, hey, this is going to have to be a team approach.
Marcella, I had a difficult time hearing the question. It was the sound quality wasn't good, so that's why I didn't respond.
Okay, is that fine now?
Is there some more information that Brian didn't address that would be helpful?
No. I think at this point we're going to have to start winding down. It's close to 3:15, the end of our webinar. So I want to take the time to say thank you for our presenters, Brett from Healthcare for the Homeless and National Council, Brian from Project Hope in Camden, Vicki from Family Health Centers in Louisville. Rebecca, if you can move us through to the past facilitated discussions conversations slide so we can do just a couple of more quality announcements as we as we begin to end down here. So just a couple of reminders, next steps for everybody on the webinar. We'll send you the recording as soon as that's available. We'll send you the slide deck also with a link to recording. That slide deck should also have live links to the resources, particularly Brett, you had a couple of things, the opioid fact sheet, et cetera, that we want to make sure that folks are able to access. So thank you all for that. We have an upcoming webinar, the next webinar in our series, Integrated Supportive Housing and Health Center Partnerships, particularly those serving older adults with complex healthcare needs. So please join us for that. And then finally, when you log out of today's event, a pop-up window will appear with a survey about this webinar. We value your input. We always want to know how to do this better. Please feel free to complete that for us, and we'll look to take your feedback for the next events. Next webinar. And from CSHers, want you to just know, just please save the date. We're going to be in Los Angeles, the CSH Summit, June 5th to the 7th of 2018. This is a national convening of thought leaders at the intersection of healthcare and housing, and particularly health centers are a real valued partner in that process. You can learn all about supportive housing in this and find out about some of the most innovative and exciting projects in the country. And next slide. And then again, we want to say thank you to HRSA. We want to say thank you to the National Cooperative Agreement organizations. We receive HRSA funds to provide technical assistance to help health centers, health center lookalikes, increase access, improve health outcomes, promote health equity, help you improve your operations and infrastructure sustainability, and then increase capacity and partnerships to address social determinants of health. Our upcoming webinars will address a lot of these projects and ideas in more detail. Certainly they'll be addressed in our summit. And if you have some specific ideas, please be in touch with us, and you'll have information on that through the survey. And with that, at 3:14, I will say thank you to everybody for joining us. Thank you again, Brett and Brian and Vicki, for this great conversation. And we look forward to the possibilities of serving more individuals and really addressing this opioid crisis. So thank you, everybody, for the work you do every day, and have a great afternoon.
Thank you.
Thank you. Take care.
Thank you, too.